just recently the FDA started emergency approval for is an antigen test. So similarly to the PCR, it detects an active infection, but again, the antigen test is more of a point of care or a rapid detection test. So it usually isn't as good as the PCR. So this is looking for, the protein fragments of the virus. But again, many of these tests, both the antigen and antibody testing, do need to sometimes be confirmed with the PCR as well. So that's why it can be confusing for healthcare workers as well as the general public, just because there's so many different tests and every test has different levels of accuracy.
That's excellent information. Just a quick follow-up question to you regarding what you asked. During the cycle of this infection, when is an individual most or least infectious, and are these points somehow reflected in the testing?
Right. So generally, you're most infectious when you're having active symptoms. So fever, cough, shortness of breath. So that's why a lot of the CDC recommendations of when people can stop isolating or when healthcare workers can go back to work circle around fever. So what they usually recommend is either 10 days from onset of illness, and 3 of those days consecutively have to be symptom-free or fever-free. But the issue is that we're not seeing that the testing exactly correlates with that, because as I'd mentioned, we're still seeing people, admitted in the ICU, very, very sick. So obviously they're symptomatic, and even some of them are unfortunately testing negative for the PCR. And we don't know why that is. Is it, is it user dependent that the person is just not doing the test properly? Is it because for some people the virus is more like in their lower respiratory tracts other than their nose? There's so many unknowns. But yeah, if you're symptomatic, then you're definitely infectious. And I mean, CDC says 10 days. I would argue even up to 14 days that you could still be infectious. And I know a lot of the WHO and a lot of other places, when you travel, especially from a place like New York, which is the epicenter, they make you self-isolate for 14 days.
That's great. Thank you for all the information. It was excellent. I would like to introduce for our next speaker, our current YPS president, Dr. Stella Ghandi. Just a little bit of background on her. She's an internist until recently based out of New York. And she is one of our senior physicians, one of the senior physicians with Oscar Insurance. And she is also currently the CMO of health startup 28 Health. Dr. Ghandi.
Thank you, Rush. I'm actually going to go ahead and introduce one of our past YPS presidents. He is the medical director of A+ Urgent Care and an ER physician affiliated with St. Joseph's Regional Center, St. Peter's University Hospital, and Robert Wood Johnson in New Jersey. Dr. Aditya Desai.
Hi guys. Can anybody hear me?
Yep.
Mm-hmm. Yeah.
Okay. It's my first Zoom call, so bear with me. Thank you for the introduction, Stella, Roshan, Purvi, thank you. Glad everybody is staying safe. I would like to take this out and thank you, Rubak, for organizing this. I want to take this opportunity to introduce our next speaker. As you all know, in the news, contact tracing is now becoming a thing, especially since we're starting to reopen the cities and the country little by little. So contact tracing is going to play a huge role. So this next physician has an intimate knowledge of how to work with big cities and coordinate massive amounts of contact tracing, which is going to be very prevalent. Dr. Jay Bhatt is a highly regarded and widely quoted expert in public health and epidemics and preparedness. He has multiple publications, has appeared on television, and has had multiple articles posted about him. He also is an advisor to the Illinois Department of Public Health for their COVID response. And as Chicago is one of the also bigger cities and also having their own coronavirus cases, no better person to talk about how to do contact tracing and the coronavirus response than Dr. Jay Bhatt. Dr. Jay Bhatt.
Thanks so much, Aditya. Really appreciate that kind introduction. Thank you, Dr. Reddy, for your leadership in keeping the community and others informed and engaging our community in this important work that we're doing together. And Dr. Rupak Parikh, appreciate your leadership as well as that of the team. who's, I think, doing really important work here on the regular to get people information and facilitate dialogue. And I'd be remiss if I didn't also just honor and recognize this moment that the country is going through a really difficult time with not only coronavirus, but the intersections of issues related to racism, equity, and justice. And I think that we are going to see an impact of what's happening now as it relates to coronavirus as well, and makes this work even more important, particularly contact tracing. And so just want to give some space and reflection on that. But speaking about contact tracing, alongside greater access to testing, contact tracing is an important tool to help control spread of disease. Contact tracing is a multi-step process of identifying and contacting anyone who's been in close, prolonged contact with a person diagnosed with COVID. So the process begins by interviewing people who've been tested positive for the virus to create a list of individuals with whom they've been in contact during the infectious period. And once the contacts have been identified, contact tracers reach out to these individuals to provide guidance about appropriate steps they can take in public, such as self-quarantine. And public health officials and contact tracing teams stay in touch with individuals via means that they communicate in, whether that be text services, reporting on a web mobile platform, telephone, really to track the progression of symptoms throughout the course of illness. And then the various state and local partners continue to connect with individuals with needed services who must quarantine as a result of being identified through contact tracing. And now there's a lot of different ways. It's not just technology. Technology needs to meet where they're at. And then contacts are provided with education, information, and support to understand their risk, what's to happen moving forward. And so this is an incredibly important issue. Communities are beginning to scale up and train large contact tracer workforces. And I think of it like this, is that, because of COVID, the public is becoming the public health workforce of the future, of today and the future. And so it's really important that we also learn from various states and cities that are doing this. And so part of what's happening is also these collaboratives popping up in which they're sharing with each other their learnings on contact tracing approaches. And you have to feed in different elements of data from different places so that that intelligence can be helpful moving forward on your contact tracing efforts. So Ditya, I don't know if you have other things to talk about as it relates to contact tracing, but that's
I guess one question I have from a personal standpoint is, so with this contact tracing, does the individuals have to provide a list of everybody they have put in contact with, like if you go to the grocery store, or if you go to or is it just close family and friends or work colleagues?
Yes. The process works like this. So say, I've been tested positive. I get a call from the contact tracing team, and then a long list of questions follow, whether that's through text messaging or telephone. Who have I seen in the last 2 weeks? Where was I in the last 2 weeks? Who was I in contact with? Where do I work? And then you contact those individuals who then also talk about the individuals that they may have crossed paths with, and so you have to identify all those that not only you've been in touch with or contact with, but also those that you might have been exposed to that are within 6 feet or in vicinity. And when contacts are notified, they aren't told who is diagnosed with coronavirus. This is really about protecting patient privacy. That's important. And so there are a number of different methods that are used to try to generate this information, and follow-up continues to happen with those individuals.
All right, cool.
Aditi, I just wanted to bring up one quick point about contact tracing. It was such an essential piece. Recently when they started reopening America in specific states, we had a lot of, especially this last weekend, a lot of extracurriculars and partying and socializing going on. And it was such an important case. You saw in Lake Geneva that they were able to contact trace one specific individual that had COVID and that was spreading COVID, and they were able to contact trace to other individuals that person was in contact with over that weekend. So it's an important tool for identifying and then isolating other individuals and quarantining.
Yeah. Dr. Briggs says, well, I think this is critically important for reopening for testing strategy, for predicting where you might advance efforts. And we even saw this in the Ozarks over Memorial Day weekend, where an individual identified there positive with coronavirus did then connect back with all the folks that were there. And so that even the businesses will send messages out in partnership with the contact tracer teams. And so we've seen this in Ebola, Zika, foodborne illness outbreaks, even in places around the world where contact tracing has been done. It's got decades-long evidence around it, but the scale that we need in this country is significant. So Johns Hopkins University estimates that the U.S. needs at least 100,000 additional public health workers to help with contact tracing, and that they've in fact put forth a contact tracing course that thousands of individuals have taken so far. And I think it's going to take a community of collaborators to move contact tracing forward. And I know that Dr. Shah, who you'll hear from later, will talk about how testing, data intelligence, and contact tracing also fit together.
Awesome. Thank you, Jay. Yeah, contact tracing is definitely going to be a huge role. And it's, as Jay said, it definitely is decades worth of data behind it. And from a personal note, I can say that our hospitals are trying to do that. And it's definitely a hard work given all the language barriers and whether people can come in, remember who they came in contact with. I mean, we all come in contact with so many people, specifically the way our jobs entail. So, Jay, I thank you. Definitely, we have to definitely help our colleagues in this contact tracing and fight this virus head on with everything we can. So I'd like to take this opportunity now to turn it over to, I believe, current MSRF president, Dr. Prachi Dua, and she's going to take it from here.
Actually, Pooja, Dr.
Sorry.
She's the current president.
Current president. Sorry, my bad.
That's okay. There's a little bit of a confusion there, but hi everybody. My name is Pooja Kinkabwala. I am the MSR president and an endocrinology fellow in Miami, Florida. Very excited to introduce our next speaker, who is a former MSRF president. He is a dermatologist in Manhattan and a digital health entrepreneur. He is the founder of the tech startup Health Digital and has been doing amazing things in the world of technology and medicine. So I'd like to introduce Dr. Dhaval Bhanusali.
Hey, can you guys hear me?
Mm-hmm. Yes.
Hello from New York. Certainly an interesting time over here, both with the virus and also with the protests I can see from my window currently. So I hope you guys are all safe and continue to be so. So I'm happy to moderate this side of it. I'm going to be introducing Dr. Nirav Shah and going back with him about talking about a little bit more about the testing aspects of this and more so kind of where we are with everything. Are we flattening the curve, not flattening the curve? Should we be testing everybody? When is the second wave coming? So Dr. Nirav Shah is a senior scholar at Stanford University School of Medicine. He helps lead COVID-19 epidemiologic modeling efforts and is an advisor for HealthWeather.us and COVID Act Now. He's a global leader on the strategies required to contain COVID-19, frequently seen on BBC World, The Economist, Wall Street Journal, and other ventures. He's an internal medicine physician, graduated from Harvard College and Yale School of Medicine, and he cares for patients at the Stanford COVID Clinic. So, Dr. Shah, I am delighted to speak with you today, and hopefully you can hear me. And I wanted to just jump into it. What are your thoughts on kind of where we are in terms of flattening the curve? Have you been monitoring the R naughts? R naughts, if you want to explain, will be useful for us to figure out how well of a job we're doing. And we'd love to hear more of your thoughts.
Thank you very much. I appreciate the kind introduction. I know someone has some slides up. If they can please post them for everyone to see, and then we'll go through them quickly. I can try to do it myself if you prefer. Okay, let me get them done.
Are you able to share the slides? Otherwise,
let me just.
If you can, yeah, that's
yeah.
fine.
I'll just get them myself.
Okay, perfect.
So there we go. So
yeah.
Thank you, everyone. So I just, by way of disclosures, I am an advisor to COVID Act Now and KINSA, which I'll discuss today. Otherwise, all of these views are my own. So as we think about the next few weeks and months, what are the things we as physicians, as leaders need to be following closely? Wherever we are, these are some of the metrics that we need to understand and track. So let's start with RT. You've heard of R naught, R effective, RT. All of these are basically summations of how infectious a person is. So for example, if R naught or RT is the proper term because it's what it is effectively. R naught only refers to the infectiousness of COVID at the very beginning, before there's anyone who's immune to it, before anyone's doing any NPIs or other ways to block its spread. That's what R naught refers to. RT is what you're supposed to call it after that. And when you're following RT, is it greater than 1 or is it less than 1? Those are the two cut points you have to worry about. If it's greater than 1, that means tomorrow, let's say it's 1.1, there will be 1.1 times as many people with COVID as you have today. If it's less than 1, you are actually in a declining phase. And so theoretically, you want to start keeping it below 1. And Wuhan, if you remember, was a R effective of 0.3 for a long time before they've reopened. We are not even close in America. We are close in a few counties. This is where I am in Palo Alto, and we've been able to, through strict lockdown, keep it down. But if you go through this website and check out your own counties, and this is kept up to date across almost every county in America, what is the R effective? You want it to be below 1 and staying there for about a week or two before you start to really think about opening things up. The next thing is hospital and health system capacity. Obviously, we don't want to have what happened in New York happen anywhere else. And this is an example from Louisiana, where you can track it and you can see how many beds there are and how many people with COVID are in the hospital today. And depending on what people choose to do, if the red dotted line is if restrictions are lifted versus if you keep going down the same trajectory with whatever shelter in place and other non-pharmaceutical interventions you have in place, what do you expect to happen with health system capacity? Clearly, a very important metric that's going to become much more important as we hit our second surge. Testing capacity is very important. We talked about the 3 different types of tests at the beginning, but I think what we haven't really gotten into enough is how are we doing as a nation? And until now, for most of America, we still don't have enough tests. And by that, I refer to the PCR tests, the nasal swab tests that are still mostly used, not the spit tests or others. And so we're restricting those tests to nursing home residents, first responders, healthcare workers, but not just everyone. And when you restrict a test to such few people, what happens is you're going to get a high rate of positive tests. Only when you do really broad testing, such as they've done in Australia, New Zealand, Taiwan, Hong Kong, South Korea, does the positive test rate start to go down. And so, for example, in South Korea, when they had a lot of rising cases, they weren't able to keep up with the demand by testing enough people. After a certain point, they did meet that. And what happened is that when your positive test rate gets below 3% and stays below 3%, that's a sign that you have sufficient testing capacity relative to the number of cases in your community. That means you should be testing asymptomatic people broadly and only finding a few positive cases relative to the number of PCR tests you're doing any given day. So please watch this rate. When you hear folks say we have enough testing, go to your county's website and see what test positive rate is, because I'm almost sure that most of America, we're still not where we need to be, and especially in the Midwest and other areas that are going to be flaring up with the second surge soon. Trace capacity, Jay did a great job talking about this as well, but it really only makes sense to talk about tracing when you've tamped down all of the other numbers. You can't really start to trace people if you have thousands of people who are still testing positive. Are you realistically going to capture every contact of that person within 48 hours? Not even close. 100,000 is a very conservative estimate for the number of tracers we need in America. I think we are having the wrong conversation. There's no chance that we have enough tracers today. And so the focus on tracers is a little premature. Only after we've kept it down, kept the test positivity rate 3% or below, made sure that our effective is less than 1 for weeks, can we even begin to do tracing. About 3 states today out of all of 50 states are at a point where they have sufficient trace capacity for the number of cases they have. And that's today.
Oh.
Yeah, so what does that mean? So CIDRAP, a group out of Minnesota, came up with various scenarios, and they are looking at scenario 2 as the most likely scenario that the US will see, with a large second surge, much bigger than the first surge, coming in the fall. Based on what I've seen on the news and how crowded locations have become, I'm actually worried that the second surge is going to look more like scenario 3, where we will get a second surge even earlier in all of the areas that that have a false sense of security, because they think New York, it didn't really happen, or it wasn't really as bad as we heard. And so you're seeing the crowded beaches and lakes and resorts of pent up people. And that's going to be a really a bad situation for Americans. Finally, how effective are your interventions? This is a really interesting question. Are things working? And this is from Apple Mobility Trends. This is basically taking people's cell phone search data and seeing where they're going. And across the world, you can see how people are either sheltering in place, not moving around, or are they getting back to normal? And it looks like most everyone, other than Italy, which is still not yet there, is getting back to normal movement around. And it's worth going. There's multiple websites that use cell phone data, use tracking data, use various sources to see how much people are moving around. And I think this is a good early signal to what's going to happen in terms of second surges. This is a very interesting website. Imagine if you had 1.7 million thermometers across America that people have in their medicine cabinets, and when you feel sick, you take it out and you check your temperature. Well, what this website did in early March, they were able to take a 20-week prediction of where flu is going to be based on 8 years of data, how much flu is normal in a given community, and you subtract out from what you observe in the fevers across America to what's expected from normal flu, and what's left behind is atypical illness. And this has been a highly sensitive and specific measure of COVID in the community at the county level for most of America. If you see, this was also good at seeing if your measures are having an effect. In Miami-Dade, after they put the restrictions in place, fever curves went way down. Makes sense, right? If you're having an effect, you're going to stop COVID, you're going to have fewer fevers. This also is a superimposing 2 curves. The blue curve is the COVID curve, which actually happened 18 days earlier to the death curve. So it tracks very well. It's now been validated in about 85% of the states across America where they have sufficient thermometers that this works. And I'll stop there and we'll leave time for questions.
Sure. So that was very helpful. Thank you. So I had a few thoughts. You mentioned some places that are still slow to get mass testing. One of my tech companies does do testing and coordinates in the Midwest, and we've seen very quickly the Midwest is not the best, most efficient place to test. But it brings a kind of a broader question. So a lot of these companies, particularly in the Midwest and a lot of these blue collar towns, they need to get their workers back to the workplace. What does that look like? Is testing, I think amongst all of us as doctors, we're going to say yes, testing is necessary. The kind of pushback we've heard is, when do you test? Who do you test? How do they qualify? If they're coming back to a factory, let's say, who do we prioritize to get tested, and how do we monitor? Do they get tested every day, every week, every month? Is there any kind of consensus thoughts on those, or do you have personal thoughts on that?
Yeah, if you look at countries that have sufficiently opened or stayed open, places like South Korea, Germany, Taiwan, Taiwan never actually did a shutdown. I think one school in Taiwan was shut for 2 weeks. Other than that, even school kept going as usual. And so they have extremely broad testing strategies where you hit large percentages of the population several times, right? It's not just that you're tested once and you're done, but that testing tamps everything down, then aggressive contact tracing, quarantine, and repeat, right? That box-in strategy only happens and works when your number of cases are very small and manageable. For most places, we don't have even close to enough tests yet. So it's not realistic to say that you're going to test every worker before they come in. Yes, you're going to test essential workers. Yes, you're going to test hospital employees, maybe people at grocery stores and all. But for most people going back to work, it's not going to involve testing. It's going to involve things like a smart thermometer at home before you get, you pass on COVID to everyone on your way to work using public transportation. You want to stay at home. It's going to take stay-at-home policies that you get paid if you don't show up at work, or you show up at work if you think you have symptoms. We're not doing that very well, right? And so the approach we're taking is actually de facto a herd immunity strategy in America. What does that mean? Look at Sweden. Look at Brazil. What they're doing is exactly what we're doing. We are going to let it run wild until we hit it. And by the way, there's going to be, what, 0.3% mortality. So what, 0.3 of 300 million people, you can do the math, right? So we are de facto approaching hundreds of thousands of deaths in America before we get this under control. There's small signs of hope. You know, people who are older than 60 or have multiple chronic conditions are staying put. They're not risking it. They're not trusting everyone else. So that's a good thing. We're learning that most of the mortality is in nursing homes. 40 to 80% is perhaps in nursing homes. So for what it's worth, hopefully they will be relatively protected because we're doing much more testing there. But for the rest of us in America, it's not looking good.
Yeah, no, I mean, it's true. And it's interesting with my own family. I've told my parents I'll see them in 2021 because there's some risks you just can't take, right? But it'll be interesting. Places like here in New York, our offices are now semi-open. We're doing the best we can. We have non-contact thermometers. We have plexiglass. We're looking at different kinds of room fuming or ventilation and things like that. But I don't think there's a perfect model. But it really is going to take a motivated public. Again, it's going to be interesting with how things look in 2 weeks with, as Dr. Butt had mentioned, there's a lot of, we have to be sensitive to what's going on in the world right now. The second, the unintended consequence of that is this might be a quick spark for that second wave to come a lot faster than we otherwise would hope so. So it's going to be, it's going to be interesting, but I think it's important to have these kind of webinars and have doctors lead the discussions and not politicians or anybody else, because people need to look at leaders to kind of guide them, right? And so hopefully from this webinar, a lot of people will be leading their own communities into this next phase. And I'm sure a lot of people have a lot of questions. So I'm going to defer to Dr. Seema Arora and Dr. Suresh Reddy and let them kind of take the baton from here and see what kind of questions we have.
Good afternoon, everyone. I'm Dr. Seema Arora, Chair, Board of Trustees of API. And at this time, I would take, it's my pleasure to introduce Dr. Prachi Dua, who is a physician from Long Island. She attended college and medical school in New York. She pursued her residency in ophthalmology, SUNY Downstate, and then completed a cornea fellowship at Manhattan Eye, Ear, and Throat Hospital. She joined Northwell full-time and fellowship and works at Manhattan Eye and Ear Hospital. Dr. Dua has been actively involved in API and served as the president of MSRF section of National API last year. So I would like to invite Dr. Prachi Dua to take over the question and answer section from here. Thank you. Dr. Prachi Dua, is she unmuted?
Yeah, she's unmuted now.
Okay, sorry about that. So my question is addressed to Dr. Purvi Parikh. If you had a negative PCR as a surgeon, how often do you have to basically retest yourself? And what is the value of actually doing antibody testing if there's poor sensitivity and specificity all around? And how should we actually interpret these results, especially when patients and physicians are going to different facilities to get the testing? And last, is there any advantage to actually doing antibody testing and nasal PCR at the same time? Or is there an advantage to doing both or just antibody testing alone?
All right, so those are all very good questions. And, you know, around healthcare workers, the criteria and standards have shifted. And of course are a little bit different than the general population, because there is a demand for healthcare workers to get back to work and, you know, be available. So we don't have a shortage of our workforce. So generally it depends on many factors. I would say where you are, where you're located, where you're practicing makes a big difference. So starting with the PCR question, if you're negative, again, there is that 30% false negative test. However, it would also depend on if you were symptomatic or asymptomatic, if you were actively treating COVID patients, because then that would change how often you would have to be tested. If you were symptomatic and negative, you know, currently, at least here in New York City, healthcare workers are being treated as, you know, COVID until proven otherwise. And even when proven otherwise, it's still being viewed as COVID-19 because it's so widespread. You're saying 1 in 4 New Yorkers have been exposed. Generally, the CDC guidelines for healthcare workers is that, you know, 72 hours with no fever or a negative PCR, either a symptom-based or testing-based strategy can clear you to go back to work. Now, again, it depends, like I said, that your region where you work, are you in a place where there's a very, very low incidence of COVID PCR? Then that may dictate that you don't have to be retested as often. But as Dr. Shah, you know, rightly pointed out, it's not a one and done thing, especially if you're continually exposed to COVID patients and you're working in a hotspot. And then the antibody testing also is complicated. I don't know if all of you saw, there was a CNN article that came out about 5 days ago where the CDC said basically it's only 50% accurate, the antibody testing, depending, again, where you are. So a test may have a very high sensitivity and specificity, but if you're in a region of the country where the density of COVID cases are low, ironically, that may make you miss many of the positives as well, even for the antibody testing. So again, all of this has to be taken with a grain of salt. I think it is helpful to get both tests, especially if you know that they have a high sensitivity and specificity, and especially if you're someone who is continuously exposed to COVID, such as a healthcare worker. However, I personally, and I don't think anyone else as of yet, should change how they interact with these patients. So it doesn't mean that you should be wearing less PPE. It doesn't mean that, you know, you should have that, you know, false sense of security. But a lot of these questions, and, you know, Dr. Shah, correct me if I'm wrong, are very geographically based and situation based too. So it's not a great answer. But I think there is some utility to getting those tests, but you need to know what tests you're getting and the accuracy of said test.
Okay. And how accurate is our ABOT, like molecular test?
Right, that's a great question, because initially when the Abbott testing came out, it was boasting very high sensitivity and specificity. But at our institution, NYU, we actually used their rapid point of care testing against another companies that also had rapid testing, but the Abbott test was a 15-minute test, and the other one that we had compared it to was a 45-minute test. And we found actually that the Abbott test missed more than half of the cases, up to 30 to 48%. So again, it complicates the picture, right? Why are these point of care tests missing things that are out of the range of what their specificity and sensitivities initially said? And there's a lot of thoughts behind it. We know point of care testing in general is not very reliable. The rapid strep and rapid flu tests are perfect examples, right? We know that they're not as good as the culture and PCR. And, you know, it's not ideal because we're developing these as we go. But so, yeah, what we found at our own institution was that the rapid Abbott test, the 15-minute, the swab, so not the antibody test, the swab for active virus was not as reliable as we had initially believed.
Okay. And is the saliva test any good at all? And is there any progress being made with a viral load test for COVID?
So the saliva test does show some promise. Again, we need more data behind it to see how the sensitivities and specificities are. Again, as Dr. Shah had mentioned, wide-scale testing really would help us. in seeing how accurate these tests are, how many of true positives, true negatives we're able to pick up. The viral load test, actually, I personally don't have a lot of experience with, so I can't comment on that one, but it would be interesting to see.
One of the people on this forum posed the question that if you're immunocompromised and are on tacrolimus as a liver transplant patient and a physician, like what would you suggest? When is it safe to go back to the office?
Right. So that also is a very good question. It comes up a lot, especially a lot of healthcare workers, not only on immunosuppressants, but also that are in high risk categories, diabetes, obesity, elderly. To be honest, it is a very much case by case basis. And it also depends on how much you'd be interacting with patients. So, you know, we have a lot of patients, especially me being an immunologist, I have a lot of patients that are on immune suppressives or biologics. And for the most part, the general recommendation of both the immunologic and rheumatologic communities is to continue it, because kind of ironically controlling inflammation in your body comes out to better outcomes with COVID-19, because we know there's predispositions for cytokine storm and other inflammatory systemic conditions. However, if you're a healthcare worker, I think the pros and cons and risk benefit has to really be assessed. I would want to know, how much are you working with aerosols? How closely are you working with COVID-19 patients? Are you in a place like the ER or the ICU? It's very case by case. You know, what is your age? What are your other comorbidities and risk factors? All of those things have to be considered.
And what is the risk of transmitting COVID if you are asymptomatic?
So we know that asymptomatic carriers do transmit it. You know, the study they did on a cruise ship, almost 18% of people were asymptomatic carriers. Here in New York, just based on our random testing, we found that up to 20% now may be asymptomatic carriers. So there is a real risk. And the problem with the asymptomatic carriers leads back into contact tracing, right? Because many of us may not even know we're asymptomatic carriers or who we're coming into contact with while that's happening. The current recommendations are, if you do test positive, that's the PCR or for the active virus, and you're asymptomatic, you should self-isolate. CDC says 10 days. I would even recommend 14, because we know that symptoms can develop 2 to 14 days after. So it is a big problem, and we know a lot of the population are asymptomatic carriers, both from studies done in Italy as well as here.
Okay. And as a surgeon, I think on behalf of all the surgeons, like, what is the advantage of doing pre-testing for surgeons, especially for those that are exposed to like long hours with their cases?
You mean pre-testing for the patients that are coming in, or
the surgeons themselves?
For the patients, you mean? Oh, okay. Yeah. So I think it is helpful, because again, one, it gives us information. We don't have those testing capabilities that places like South Korea and Taiwan has. So it again tells us how many people are exposed. It gives us a lot of information about asymptomatic carriers, because a patient may present for surgery and feel fine, and then lo and behold, their swab may be positive. And again, it has a big impact on exposure to hospital staff, to other patients. It helps guide treatment in terms of how long that patient has to wait till they can come back for surgery. So I think it's very important and crucial. I would even argue any patient coming to the hospital for any procedure probably should be swabbed. And I think that is the case at most places.
And for surgeons too, they are doing things where they are testing surgeons, and then you'll be on for a week, and then you'll be off for a week, and then before you go on for another week, you'll get tested again, things like that.
Yeah, makes sense.
All right, thank you. I'm gonna head the baton over to Stella, who's gonna ask some questions as well.
All right, thank you. Purvi, I just want to thank you. Being a New Yorker, coming into the Midwest, being asymptomatic but self-quarantining right now, a lot of that applies to me. So thank you for all that fantastic information. I've actually got a question for Dr. Jay Butt. You got a great article recently that came out with ABC News about contact tracing. I wanted to go specifically into travel precautions that you would recommend. I mean, what specifically should people be doing besides wearing a mask? I know there's a lot of fear and uncertainty about flying right now. Should they be flying? What else can they do to to make sure that they and others around them stay safe.
Yep. Thanks, Stella. And I think, you're a great example of what someone should potentially do, post-travel, and sort of thinking about your isolation and quarantining. I think, if you don't have to travel, my view would be that you shouldn't. And at least now, as Dr. Nirav Shah illustrated, we still are in these potential waves where there's folks that are exposed. We're not doing enough testing, so we don't know the people that we may come in contact with that may be infectious. And so I think that's important. I think you're also going to have to plan and think differently about your interactions in the various ways of life moving forward. We recently talked about how do you socialize in a safe way, and not only continuing social distancing, prevention and hand washing and all the things that we know of. The mask is critically important. I mean, I still see so many people without masks in public spaces, and they're not only putting themselves at risk, but putting many others at risk too. And so, I think that there was also a question here about the applications, and I think Nirav may want to comment on this too, but there are a number of folks putting forth contact tracing technology using smartphones and Bluetooth to alert those close to someone infected. Some of those can be helpful. Some of those also have limitations. Users would have to opt in. So what's the chances that you might engage with someone who's actually also using the application? And it's not clear whether enough people will do so to make the effort worthwhile. And people without smartphones won't get notified. People that aren't using SMS or text messaging won't get notified. And you think about all the vulnerable people in our communities that may not have access to that. They're going to be those that might be left behind. And so I think we just got to think about meeting people where they're at with the various technologies around contact tracing and engaging with understanding who's at risk and who's affected.
Thank you. I'm going to go ahead and toss the baton over to Dr. Pooja Kinkawala because I know she's got a few questions as well.
Yes, and actually, Jay, you brought up a good lead into my next question, which is for Dr. Nirav Shah and for Dhaval as well, about the role of using platforms by Google and Apple and contact tracing, what other technology is available in that standpoint.
So I can kind of but I guess I have to disclose my pseudo conflict. I've done work with Google and Apple Health recently with some of this stuff. I think, the issue is kind of what Dr. Butt mentioned. There's some limitations with technology. There's a hospital we were speaking with in Illinois where they had 40% of all patients were testing positive that had symptoms, which is very high. The problem was it was a Hispanic population, doesn't have access to certain testing or certain care and technology. And what do you do with a lot of these populations who are spreading virus who don't have smartphones? There's a privacy issue in this country. People don't want to really be watched, quote unquote. Other countries have been successful, but it's right now it's a good litmus test of how little the public trusts the government, right? So that's an issue. With Google and Apple, they've been pretty explicit about they're not creating the quote unquote apps for tracing and monitoring people, but they're providing the tools that states and counties can use to build out the technologies they need to do something like that. So they're kind of like, look, we'll give you the tools, you will have to decide how to do it. I think just to compromise a little bit on the people's kind of vulnerability there, they want to make sure that they're not pushing too hard, too fast. Some places I think will embrace technology. I know New York is looking at it way more than others. It's almost going to be impossible to have enough contact tracers here to be following people who are jumping on subways and Ubers and things like that. But technology is a very valuable piece of this whole kind of puzzle. I think organizing people, because okay, somebody is positive, then what? How do you tag this person so you can do a repeat test in 30 days or 60 days or whatever it is? You need the organizational infrastructure. And a lot of labs that do testing, you can do testing in a field somewhere, as a drive-through. The person gets tested again, and then what? There's no continuity there. And that's where a lot of this stuff needs to really be built in. And it didn't exist before because we never had to worry about it. So now, again, as big tech companies provide the tools, it's kind of up to us to look at each individual situation and decide how do we want to approach this community? What's the best way for us to act in order to minimize? Because there are going to be fires everywhere, right? And you have to figure out how do I put out these small fires and prevent them from becoming much larger fires that spread rapidly everywhere. And so Nirav, do you have any thoughts?
Yeah, I think the only thing, I mean, those contact tracing apps only work if more than 60% of a population opts in any given area and uses it appropriately as they should, like their phone is on, it's charged, everything else. And even then it'll only decrease the number of contacts that need to be traced by about 15–20%. So it's a marginal benefit to a marginal benefit. It's really not the answer for America in any way, where we know that 44% of people are very happy with this current administration, are going to decide what they want to do on their own. Not to be political, but to the extent that we don't have good apps, but that companies, I think, have some hope where they are then forcing people who work in their companies to opt in. You don't have a choice. And so at least for people who are inside a given factory or something, you will know who they interacted with. So that's one glimmer of hope where technology can help with contact tracing in large factories in the workplace. It still doesn't control for all of the contacts outside, but should you have a positive case or a spreader, you should at least be able to contain it. And I've seen some good results in companies to date around the world. One of the companies I've been working with has been able to continue work as normal because of aggressive internal contact tracing by hiring buses to bus people to work so they don't have to take public transportation, and allowing folks who are at higher risks to work remotely or stay home and still get paid. So I think companies are going to be the leader in this. Coalitions of states, the northeastern states, the western states, are starting to get together in the absence of true leadership or the vacuum that we have centrally.
Thank you so much. My next question is for Dr. Parikh. Can you talk a little bit about the role of oral steroids for the use of on the 4th day after a patient has tested positive for COVID-19?
So oral steroids, just for a positive COVID-19, there is no good data behind it. We have used the oral steroids for some of the complications of COVID-19, oral or IV, if they show some sort of inflammatory response. But if you're someone who is recovering at home and otherwise, has no symptoms that would mitigate the need for it, then, there's no good data behind it. I treat asthmatics. So many of my asthmatics who were COVID positive, luckily were recovering at home, and they needed steroids, obviously, to treat the secondary complications like the asthma exacerbation. And again, I know we're using it a lot in children, along with IVIG and high-dose aspirin for those children who are developing the Kawasaki or the pediatric multi-system inflammatory syndrome. But again, it's not just recommended for all COVID-positive COVID-19. There has to be a reason.
Okay. And this next question is actually for both you and Dr. Shah. Do you guys have any updates on the vaccines, any timeline that you know of, any types of vaccines that are currently being researched?
I can briefly touch on that. I'm actually, as a full disclosure, in 2 of the vaccine trials at NYU. The Pfizer trial we've already started, which started about 3 weeks ago in early May. And we're still in phase 1 of that study. And then soon in July, we're going to be starting the Moderna NIH study. Again, with these trials, there are promising results that have come out from the Moderna study, but again, it was 8 patients. Good news is they did have an immune response. It looks like that immune response is providing what we call neutralizing antibodies that can, latch on to the virus. But it's a very small number, and we're still sorting out the safety too, because that's just as important as the efficacy. Realistically, I don't think that there will be anything until the end of the year earliest. I know a lot of the pharmaceutical companies, Pfizer included, is boasting something by fall, but I don't think realistically that could happen because things come up, right? For us, we've only been injecting people for 3 weeks, and we're seeing, different side effects, different ways that the vaccines behave in different people. So it takes time is the short answer.
Yeah, and just to add to that, the false hope of 8 patients and many other areas where what we're talking about is threading a needle through, basically, if everything goes right, And that's like a series of 5, 6 gates that they have to cross, each with small percentages of everything going right. Will we have perhaps a few million doses for the entire world by early next year? Now, what does that mean? That means that in the US, you're not going to get vaccinated unless you're a super high risk nursing home resident, frontline worker, et cetera. And broader availability of that vaccine is not going to happen for at least 1.5 years to 2 years. We've only been waiting 30 years for an HIV vaccine. So whatever you think of, oh yeah, why we'll get it by this year. I'm not very optimistic that we'll get that many doses by the end of the year.
Oh, thank you so much. I'm going to kick it back to YPS President Stella Ghandi.
Great, thank you, Pooja. So on that fantastic note about the vaccines, given the fact that there's so many different mutations out there, how many mutations do you think there are? How is that going to affect vaccine production? This is for Dr. Shah and Dr. Puri.
So that's a great question. And there are mutations that we're seeing slight differences in the virus that came straight from China to the West Coast versus those that came from Europe to New York. But it's unclear. We don't know the differences, if they're meaningful enough in terms of vaccines that are being developed and or ultimate, which mutation is going to win out. So I say stay tuned, because as you see with the flu virus, every year it mutates enough so that people still keep getting the flu. There's enough strains out there. I think there's 400 more SARS viruses that we know of, that any one of which could jump into humans. So the bottom line is stay tuned. Don't get overly optimistic. Check your news sources. Don't believe everything, even if it's coming from the CDC, because they've been politicized in ways that we know, saying that it's okay to be in a choir in an Episcopal church, even though we know for a fact that that was one of the super spreader events. So you really have to judge everything by yourself, for yourself, read the primary data, see that there's only 4 patients in the Modena out of the 8 patients who had a response. I mean, judge for yourself is what I'm trying to say.
Yeah, I think that's very good advice. And I agree, any RNA virus can mutate. We know there's different strains. The one glimmer of hope, though, is that it seems that coronaviruses are more stable than some of the other RNA viruses. But again, I agree with Dr. Shah. Time will tell, and all of us as physicians have to be very, very critical in everything we read.
Great,
Yep.
Thank you. Another question we've got is it possible for someone who's recovered from the virus to test positive again? I mean, I know we've seen cases in China where they're not sure if it's a reinfection or if it's a new strain or what it is. Do you guys have any comments or observations on that?
I think the China studies have now been shown to mostly be possible bad testing in the first place. So they don't actually think it's the same person getting it again, but that the first test was wrong. And so we don't know, to be frank. But if it's like other viruses, you shouldn't be getting it again that quickly, but we don't know.
Yeah,
And the other thing, I would add, sorry, let me interrupt. The other thing I would add is we know also sometimes a PCR can stay positive weeks after people are symptomatic. So I agree that, the first negative may have been a false negative. And then again, it just picked up the same infection.
Jay, did you have anything to add to that?
I was actually just going to add Purvi's view as well, and what Nirav said. So I think that they both covered it.
All right. And the last question we have is, do you think the antibody testing can be used for convalescent plasma donors, to expand on the criteria for convalescent plasma donors? That's open to all.
Well, absolutely, right? Because we need to see if somebody has antibodies and how high their titers are. I know for Mount Sinai, they use very strict cutoffs to even see if somebody is eligible as a donor.
And I think we just also have to be skeptical in some ways, and just think, because some of the antibody testing isn't the grade that we need it to be. And also that there are a lot of different requirements for convalescent plasma donation. And we know that it is working, and it can happen quickly, versus a hyperimmune globulin treatment versus the vaccine treatment. So there's sort of these three layers of treatments outside of the medicines that could be useful, but hyperimmune globulin treatment may take more time. And so convalescent, for now is the best we've got.
There's some additional questions, and this could be addressed to everybody. What is the biggest challenge for viral load testing development, and what is the role of herd immunity in general here when vaccines are being developed?
Let me
So
start with the second.
Yeah, you can go ahead.
With the second one, with the second question, herd immunity requires 60, 70% or more people to have sufficient antibodies so that they don't get infected or go on to pass the infection on. So that's a high level. Even in New York City, 20, 25%, that's very high. Most of America, it's under 2.5, 3, 4% in the large studies that we actually believe. So with very few exceptions, to get to herd immunity of 60, 70% will require a lot of people dying.
Or a vaccine, hopefully.
That's my real hope. But, let's hope.
Yes. No, I agree. Absolutely. I mean, and Sweden is a good example, right? Because, they didn't do the restrictions and they still are nowhere near herd immunity. The viral load question, I don't know enough about that test. I don't know if either of you do.
Yeah, I can't speak to that. I can speak to the fact that more and more information is showing that the 2 days pre-symptoms onset are also highly infectious. There appears to be a lot of viral load and a lot of spreading going on right before they become symptomatic. So viral load probably has an important role to play, even in the pre-symptomatic who will become symptomatic folks, but to be decided. We don't know the viral load tests yet.
And one of the questions also is regarding like plasma donations. Like, what are the criteria? Does someone have to be IgM positive or IgG positive for it?
Go ahead.
Go ahead. Sorry. No, go ahead.
No, I think that, part of it is that the eligibility requirements have been evolving over time a bit as well. And so there's, we check with the donation, plasma donation program that you might be going to, because they may have different eligibility requirements. You have to be fully recovered. You also have to have symptom-free over a period of time. And then even if you're being treated for a chronic condition, you need to look into as well. But they expect you to wait 28 days from symptom onset, and then also have the cleared test ×2 some places as well. And you need IgG, which shows on the antibody that positive to donate. Because if you don't have IgG, you're not gone into that recovery phase.
Right. And generally IgM could mean that you might still be infectious. So most of the protocols I'm aware of is that you need to be IgG positive only to be in those studies or to donate.
Dr. Lokesh Adara had a question. Dr. Adara, you can address it.
Hi, can you hear me?
Yes.
Mm-hmm. The question is, we presented it through the RP, oral steroids, like Purvi, I'm an allergist too. And several allergists saw, even I have some patients who has viral infection, they were treated with steroids and antibiotics, they did well. And nobody gotten worse with steroids. We strongly believe, I mean, these are all 60 years old, 50 years old, 30, 40 years experienced allergists and family doctors, believe it is a outpatient disease, COVID-19. And especially when you look at the Lancet Journal of China, on the 4th day, all the parameters, including not the D-dimer, ferritin level, those higher are the ones who died, especially 70, 80, 90 years old. When you put the steroids, I think we believe that half of the deaths can be prevented. That's a big statement. So I like to, I think someone of us, I think maybe Dr. Parekh is in news channel. Can you look into this issue and see when we need attention to the media? I think that's the biggest gap in the pandemic. And after our webinar, we sent the survey, 85% think they want to give the steroids because people are not dying of the virus, they're dying of the hyperinflammation. And their IL-6 blocker, yeah, Actimera. That's only one of the 40 cytokines. And steroids will block early in the sooner. So I just wanted youngster look into this and then take it to challenge because that's where we think strongly. I'll stop here. There's a comment and anyone can comment on this. Thank you.
No, I mean, I agree completely. I mean, we've been using steroids for not only viruses, but many other infections because we, you know, all of us, not just allergists, but many clinicians know that with any infection, often the inflammatory response that comes with it is what is dangerous for the patient or harmful. So absolutely, you know, we use steroids for flu, RSV, so many other viruses. My point was that we don't have any good studies yet. So that would be a great next step is looking at steroids, especially in the outpatient population. I for sure have given it to COVID patients that needed it if they were wheezing or coughing or whatnot, but I don't know of any studies that have been done, and that would be extremely interesting to see.
This is Suresh Reddy. Can I speak for 1 second?
Go ahead.
Another simpler study would be, because most of the patients some of the patients could be on chronic steroids. If we can look retrospectively and see any of these patients on chronic steroids got infected or died from COVID. So that will be a simpler study. I don't know if anybody has done that kind of study.
You know what is actually interesting? In New York, we thought initially that asthmatics and people with COPD would be at higher risk because COVID attacks the lungs. But out of the New York data, actually, they weren't even in the top 10 of the people who had the most severe disease. So, and those usually are people who are on inhaled steroids daily, you know, so there may be something to it. It would be very interesting to see.
And the next question is there a role for the use of anticoagulants early as there's DIC in these patients? And at what stage would you use these anticoagulants?
Yeah, so this is, again, a great example of our evolving knowledge. A lot of these signals are going to turn into, hopefully, science, whether it's steroids, whether it's anticoagulants, all of those, we really must wait until the double-blind randomized controlled trial before we start broad application of these ideas, which makes sense, but they can have unintended consequences. You know, there may be subsets of patients who actually do benefit from steroids and some who get harmed. Similarly with the anticoagulants, we don't know enough today to make any statements. And it's not that, you know, the absence of evidence doesn't suggest the absence of benefit. It just means that we need to do the studies.
And just to jump on that one, in derm world, we're kind of sitting on the sidelines of a lot of this, but we've actually seen these COVID toes, as people have coined them. Mm-hmm. And it's believed, at least in the dermatology world, these microemboli are being thrown out to the toes and fingers. And, you know, the role of, I mean, I think Sinai did have a positive study with the anticoagulants, but again, you can't give everybody these medications and assume no consequences occur, right? So if you give the wrong person the wrong thing, you can make things worse. So do we put people on aspirin if they have it? We've thought about it. Most dermatologists do not, or baby aspirins or things like that. I think in general, when you're looking at the protocol here, it's evolving so fast. But you know, people like Dr. Parikh, who are right in like kind of the lion's nest, if you will, are seeing a lot of the complications that occur from people jumping into medications too fast. And I think it's imperative that we don't respond to media reports in the sense where, you know, things are politicized, and we have to look at the raw data and what's coming out of the actual journals themselves before deciding amongst ourselves what's worth doing, what's not worth doing.
Thank you. And just a few more questions related to this topic. Is there any data on the relationship between smokers and COVID-19? Are they at increased risk? And also, does anyone have an opinion on the use of hydroxychloroquine?
I mean, I think, my view on the smoking, I think it's a state in which we know it impacts cardiac disease and a risk for things that accelerate chronic disease. And so there is a study by UCSF that suggested it significantly worsens COVID-19. But, again, we don't have the depth of trials around this. But follow the science and what we know about tobacco and its implications on all sorts of conditions, I would say that it just impacts the inflammatory state and recovery and the ability of the body to fight the virus. So,
as for hydroxychloroquine, I would suggest you look at the multiple negative studies that have come out now showing that it doesn't help and it does harm many people. That there have been no validated clinical trials that show it helps. Across the board, there are now 96 diagnostics in treatment that are authorized diagnostic tests. There are at least 72 assets that are in human clinical trials as we speak of right now, and 12 vaccines in human clinical trials. So please follow those directly if you're interested in some of these, but wait for the evidence before you start prescribing them.
Yeah, I know the NIH started one for hydroxychloroquine in milder cases, so it'll be interesting to see if that shows anything. But I agree, so far it doesn't seem to show any benefit.
Is there anything that we can do at diagnosis to prevent progression? So initially, when we started seeing a lot of cases of COVID-19 here in New York, if you were statting above 90%, the patients that came to the emergency room would be discharged. But now, like the thought at where I work is that basically, if they're seeing that even if patients are statting at 91 or 92, like they're admitting the patients and starting like treatments early. Has that changed across the states in terms of management? And what is your opinion regarding how to prevent progression in these patients?
So from what I understand, I know at least in New York, in speaking to my emergency room colleagues, ICU colleagues, they are also being more aggressive in, people who are statting at 90% are being admitted, at least under observation. And treatment, we're finding that early treatment does help. A lot of the studies that we've done so far were when people were already intubated or critically ill. So now the new wave of studies are focusing on earlier treatment. So it'll be interesting to see, but anything specific, I would say, depends on the patient and how they're presenting. Every patient comes in differently. Is it someone who's having clotting abnormalities, someone who's having respiratory issues? I think the treatment is directed case by case, and every institution I know has different protocols that are also changing dramatically from March until now.
Yeah, I think I've seen one trend of trying to keep people off vents at any and all costs. To the extent that you prone them, you do whatever you can.
Right.
A vent is a failure.
Okay. And what is the initial treatment protocol now in hospitalized patients?
It's supportive care. It's still, it's oxygen as needed. It's fluids. It's not, there's no, it's not remdesivir on day one. It's wait till you need it, then you use it. And that is one of the few positives, right? That remdesivir does seem to help shorten length of stay in severely ill patients.
So Jay had posed a question. What is the initial treatment in hospital patients? Does azithromycin and hydroxychloroquine work? Is that a protocol anywhere now, given all the studies that have come out recently regarding hydroxychloroquine?
I'd reinforce what Dr. Shah said. I mean, the evidence so far that we know of is fairly strong in COVID patients not to use hydroxychloroquine or azithromycin. And so I think, that it poses risk to patients. And I think we need more studies to look at whether that can work. And I know that there's a study around prophylaxis as opposed to treatment. There's a study in healthcare workers. But I know that across the world, WHO has just halted some of the stuff have had in play.
And I guess one of the other questions regarding zinc and vitamin C also.
Right. So similarly, there hasn't been strong enough data for it to be incorporated into a protocol. Of course, zinc is very important in immune function as well as in stopping viral replication. But it's important to supplement it if that patient is zinc deficient. So certain areas of the world where there is severe malnutrition, or if there's a reason someone is malnourished and not getting adequate zinc, then yes, absolutely, the zinc supplementation is needed. But additional zinc, we haven't seen any benefit. And the same goes for vitamin C. Vitamin D, which all of us know is one of the strongest vitamins that are involved in immune regulation, multiple organ systems. That, of course, supplementation helps, but it's not meant as a treatment. Again, it's all part of the big picture.
So I just wanted to switch gears for a little bit regarding what's been happening in the nursing homes across the country. A large number of deaths have occurred in the nursing homes, and what is the role and need for increased testing in these nursing homes and in the elderly population?
Yeah, I'm thinking of joining the new nursing home panel that they're putting up nationally. And this is one of our biggest failures as a nation, not protecting our most vulnerable elders. And we know it's a number of things. It's no one's fault, so to speak, and yet it's low-paid workers with high turnover who are taking public transportation and being exposed to get to work in the first place, and then not having sufficient PPE and supplies to actually protect them. They are at the end of the supply chain, well after the hospitals and others who have first rights to all of this PPE. And as a result, they're reusing masks and other things, or not even, have sufficient in the first place. And then the alternative of not going into a patient's rooms is social isolation. So we're really in a rock and a hard place when it comes to patients in nursing homes. Definitely a much more wide-scale testing program is needed than is currently available. The cost structure of nursing homes is such that they're all on razor-thin margins as it is, and so they haven't had any space to do anything proactively. And so it's really incumbent on us to be the voices of what's needed. If in fact, truly across the world, 40 to 80% of all deaths are in nursing home patients, as the last study I saw said, then we know where the problem is that we need to collectively work on.
And just to jump on that, we were able to speak to some nursing homes in the Midwest, and what the issue was for them was the burden of testing was on them, right? So if somebody came from the hospital, it was up to them to test each person, not the hospital, before sending the patient out. What that did is, as Dr. Shah mentioned, they don't have the money to test every single person because you have to wait for reimbursement, things like that. They have to put up money up front, a lot of these things. And then secondly, where do you put all these patients? Do you have a separate wing of a nursing home, which is not necessarily that big, for these patients? How do you keep them separate? They already need advanced care if anything happens. So it became kind of a mess. The only kind of silver lining, I think more recently, is that the federal government did give some sort of funding, or at least on the statewide levels, they're allocating certain funding budgets to nursing homes. And I know here in New York, they're trying to create a situation where if a nursing home cannot take care of somebody for whatever reason, then they're setting up care for that patient. But this was kind of an infrastructure fail more than anything, because you can't tax that already difficult situation with so much more work. And it's just unfortunate because one person going into a nursing home that's positive for COVID-19 is essentially a missile going in and causing mass destruction. And it's one of those things where you have to be so careful with those patients. And I think now they're moving the screening towards the hospitals and putting the burden on them, which should be helpful moving forward.
I can speak on that a little bit as well. I have a team of national physiatrists and physicians that take part in rehabilitation. And a lot of the work we do is in transitions of care from the hospital to nursing homes. And one of the things that we have seen recently, and both Nirav and Dhaval have mentioned this before, up until now, there was a lack of PPE. There was a lack of enforced regulations in terms of how the nursing home owners and the nursing homes were able to isolate those patients that were positive. Also, in terms of testing, there was just a shortage of testing. I mean, we've seen it everywhere in terms of the criteria of individuals that could get tested in the hospital. You're talking about primary locations where tests are needed. But then you're talking about the nursing homes, there was just a shortage. I've had numerous conversations with national nursing home owners, and the problem was they don't have the capacity to test. Where are they supposed to test? Which laboratories? So they were put towards at the bottom of the list when it came to this. That has changed a little bit now, and funding was another issue for their facilities in terms of getting supplies for PPE, paying for it. And it's sad because, as Nirav mentioned, at least 40% of the total number of COVID deaths have occurred in nursing homes. So that is a massive failure. Things that have been done to try to fix this problem. There was a CARES Act. One of the latest portions of the CARES Act was specific towards skilled nursing facilities and nursing home owners, where they got not only paid per facility, but also paid per bed. And that was a stipend that was given. There was also, they're dictated in terms of how they're going to utilize that money. Telehealth is a big thing that is now being implemented in the nursing homes as well. Hopefully that will prevent, so you have physicians that are going from one facility to the next, to the next, to the next, also in the hospital. So if there were theoretically zero COVID patients, the fact that you're going from location to location to location, then you have a lack of PPE in the nursing homes, you're going to go ahead and spread it. And when you spread it in a confined space to this very vulnerable population, you're going to see mass hospitalizations and mass deaths. The other thing is transitions of care. It's something that we're seeing at the hospital level. You're seeing hospitals that basically are trying to have openings for their beds, ICU beds, ER beds, general hospital beds. How are they going to transition these patients to the next level of care? And a lot of the nursing homes were not accepting patients unless there was a negative test. It goes back to the testing issue that we're talking about today, which the problem was there was not enough testing involved, or not every patient that was being discharged from the hospital was getting tested for COVID to then be able to transfer to an LTAC or to a nursing home or to an outpatient facility. So quite a few major issues with it. I know Jay has been working with the Illinois Department of Public Health on this issue. He and I have been talking about it as well. So perhaps it's something that he can add to as well.
Yeah, I think that there continues, I think, you and Nirav Double highlighted the key issues. Part of the challenge also is just the way information is flowing, because you can't make decisions, act on certain things based on information you don't have. And then there's also contracted nurses. And you imagine if the workforce gets sick, then you have a number of your nursing staff out. The other is infection prevention control, really stronger in the training and infection prevention work that is done at nursing homes. And then there's kind of also protocols around how nursing homes and the transitions of care, of coming in and out of other settings back to those facilities. But it's just the overall issue that Dr. laid out, is that we just haven't developed delivery and payment for nursing homes and these facilities in the way that we need to, and that there is, I think, appropriate training and accountability for the various stakeholders in that work.
Thank you. And just a couple more questions. One of the topics is regarding PPE, as physicians return to their private practices and start working in outpatient clinics. What is your thought, Dr. Parikh, on using an N95 when seeing patients versus just using a simple procedural mask? What would you recommend? Because it's really difficult to breathe with N95.
Right. So I think my opinion, it may be controversial, but prior to the pandemic occurring, even as recently as mid-February, the recommendations was anytime you go into a droplet precaution room or someone you suspect of any droplet precaution, everybody wears an N95, and not just any N95, one that's fitted appropriately for your face, and then you discard it. And there was a new one for everyone, for each room or each time they went in. So I think that is still the right thing to do. I know because of PPE shortages, the CDC has changed their recommendation numerous times from, bandanas, the surgical masks, but the spread is there still in the outpatient setting, and it's still real. And I would argue that as a clinician, and especially if you're closely examining patients, it's important. And now if you're doing aerosolizing procedures, then absolutely you would need it. As an allergist, we've stopped doing a lot of our nebulizers and limited our breathing tests for that reason, just to not expose staff. And because we don't have access to N95s because they've been so difficult to get a hold of. But I think ideally all healthcare workers should have them, because that actually was the standard of care. And now it's only changed because of supply and demand rather than scientific reasoning. But that's my opinion.
No, I think that's not, that's more than an opinion. That's reasonable and scientific and the right approach for all of us. I mean, we have to protect our patients. We have to protect ourselves.
Right. It's just, frustrating because I hear a lot of administrators telling my colleagues, oh, if you're in the outpatient setting, you shouldn't have access to a certain mask. So that's why, but yeah, I agree.
Thank you. And one last question. This is for Dr. Nirav Shah. Should there be more of a use of AI deep learning to generate a much more data-driven strategy to fight COVID? The technology is there, but what are the barriers right now to AI at this time?
So, this is interesting. I am a big proponent of using AI to augment the work that physicians do. This is one of those areas where we really don't need much AI. We know what we need to do as a nation. We need to act as a coordinated nation using the same data, speaking the truth to one another in real time, right? The fact that today, less than half the states are reporting out daily hospitalizations with COVID is deplorable. Why? Because it's a business imperative not to share. And yet that data would give us an exquisitely perfect picture of how COVID is spreading throughout all of America. And we're not doing that. We don't need AI for that. We need people to step up as leaders. We need physicians to step up as leaders. We need all of you to step up, actually, because very few people are trusted nowadays. Physicians are some of those that are still relatively trusted. Get up there, get out there, and say what needs to be done for your community. That's on us. I'm not a COVID researcher, and yet I'm spending 70, 80% of my time on this because it's our time to do this, right? So please, we need to do what we know we need to do. We need to speak up, like Dr. Parikh, Dr. Butt, all of the others on this call have been doing, is to take time out of our busy schedules and make sure that we understand the facts, and then we promote the truth to our patients, to our legislators, and beyond.
I wanted to jump in here really quickly. Before I toss it back to Dr. Seema Arora to thank everyone and close out, I just wanted to say thank you to everyone and the MSRF team and the YPS team for joining, our special guest as well. Thank you so much. There's a lot of unrest. I think Jay alluded to it before. There's a lot of unrest in America right now. A lot of people out in the streets in a lot of the major cities that we're from. So first of all, everyone be safe. Second of all, talking about potential spikes, we might be seeing earlier spikes, and if not, larger spikes coming soon. So I'm sure we're going to see the impact of this in the hospitals in the near future as well. But just wanted to wish everyone to make sure everyone stays safe and to pray for healing, not only from COVID, but from this unrest. So thank you, everyone. And Dr. Arora, please, if you can end it from here.
Thank you, Rupak. So I'm Dr. Seema Arora again, Chair Board of Trustees of API. I would like to take this opportunity to thank all the speakers, Dr. Purvi Parikh, Dr. Jay Bhatt, and Dr. Nirav Shah, for educating us about this very informative topic of COVID testing, as well as contact tracing, vaccines, and other current hot topics. Certainly there's a lot of uncertainty and apprehensions as we go into phased opening of the lockdowns. And we all know that it's sort of an evolving, ongoing process where we will be seeing a lot of developments as we go. I would like to thank all the moderators and organizers who are young physicians of API, current or past leaders of YPS and MSRF sections of API, very proud of you guys. You did a great job, and keep up the good work. Lastly, I would like to thank all the audience for staying with us and attending all our webinars every Wednesday and Saturday. I would also like to invite you all to our upcoming virtual API Summit from May 26th to 28th. There'll be a lot of other informative webinars, and we are also providing CMEs. So please stay tuned and attend our other API events. Thank you very much.
Thank you.
Thank you.
Thank you.
Thanks,
Thank you.
Thanks, everyone.